here where I think everybody's been kind of forced to adapt given the circumstances. This was meant to be a presentation that we did in person originally, and so I've adjusted it just a little bit and adapted it to the current circumstances of COVID-19. And here we go. We're going to try to do it online, and hopefully we're able to reach a few people and have an impact. All right. So first, before I get going, I also want to mention that I did a similar version of this maybe 3 or 4 years ago. I did that with the help of someone I was working with at that point in time, a physician assistant by the name of Sean Rowe. He works over at Cooper now. He's a really good guy, a former baseball player, and we worked on this presentation together, and I did kind of the doctor part of it, and he did more of the throwing part of it. I just wanted to acknowledge that he had a vital role in the development of this here presentation. I still consider him to be a very good friend. Unfortunately, we are no longer working at the same place, thus I'm doing the presentation on my own. Which brings me to my next point. Lots of times with these talks, it's you either get a doctor doing this type of a talk, and when you do, what you do is you get good anatomy, you get mechanism of injury, you learn how these injuries happen and how they are fixed. But what you don't get a lot of is the mechanics of throwing. And the reason that happens is because Doc knows what he's talking about, or Doc talks about what he knows about, which is the anatomy and the injuries and how to fix the injuries. But docs don't have a great knowledge of necessarily the mechanics of throwing. And then on the flip side of that, you go to a coach's presentation or a coach's talk or a throwing clinic, and you may get the opposite, where you learn some of the details about the mechanics and hopefully how to avoid injury, but you don't get a lot of background into the injury. And what I'm hoping to do here today is combine a little bit of the two. I'm trying not to be too detailed in terms of the audience, in terms of I just don't want to bore you guys to death in terms of the injury and how it happens and some of the details, but it is helpful to have some of that background to put it all together and make sense of it, and thus avoid injury. So I don't claim to be a throwing mechanics guru. I know the injury is better, but I have a pretty good understanding of the basic mechanics of throwing, and I'm going to go through some of that with you guys today. All right, so a little bit about me. I was born and raised in New York, born in the Bronx, grew up in Bethpage. I did my undergraduate. I went to college at SUNY Binghamton, State University of New York in Binghamton. I was a college wrestler at Binghamton. I went to medical school at Georgetown University and did my residency in Central New Jersey, a small community hospital named called Monmouth Medical Center. I did a sports medicine fellowship out at Allegheny General Hospital. And hold on, I'm just messing around with this. There we go. I did my sports medicine fellowship at Allegheny General Hospital in Pittsburgh, Pennsylvania. And there we took care of a lot of teams. The main focus for me was Pittsburgh Pirates as well as Slippery Rock University. And that was the Pirates part of the equation. Was a spectacular experience. Currently I'm a board certified orthopedic surgeon. I've gone on and obtained my specialty boards in sports medicine. I've been in practice for over 10 years, and I joined the reconstructive team a little less than 2 years ago, about a year and a half to 2 years ago. All right, what I'm going to do with this talk, it's maybe a little bit out of order, a little bit counterintuitive, but any reasonable talk really starts with the anatomy. Then I'm going to go through some of the throwing motion. Then we'll talk a little bit about adaptations of a thrower, which legitimately happens as a kid is growing up. Some of the changes that help theoretically prevent injury. Then we're going to talk about the pathology of injury. There's generally a cascade to the breakdown. I'm going to go through some of that. I'm going to make one mention or two mentions of valgus extension overload, which really is more pertinent to your elbow as opposed to the shoulder. But I'm not really going to spend a whole lot of time on that because this talk is really meant more to talk about the shoulder. It's just hard to separate the two sometimes. And then finally, I'm going to talk about avoiding injury and throwing mechanics review. And those two things tend to go together. All right, so this is an illustration right out of Frank Netter, which is one of our, in the world of medicine, kind of the the crux of anatomy. Everybody gets the Frank Netter book, and everybody studies Netter. And just to go through it real quickly, and I'm going to use my mouse because I don't have a laser pointer, and I think it might be the best way to try to explain what's going on. But in general, this is looking at somebody from behind, looking at their back. You can see the deltoid, large muscle over the shoulder that wraps around the entire length of the shoulder, rear, side, lateral, and front. I also want to point out over here the trapezius, large, strong muscle in the back there. And if you notice what it attaches to, this bone right here, and which is also part of this bone, is your scapula, your shoulder blade. The shoulder blade is one of the keys to throwing and to avoiding throwing injuries. If we strip this layer away, underneath what you see is over here your rhomboids. Also, very key muscle. You see they attach right to the what we call the medial border, or the side, the inside portion of the shoulder blade, the scapula. Also, we've stripped away the deltoid and the trapezius, and you see up this muscle up here, that's part of your rotator cuff. For those of you who are wondering what a rotator cuff is, it's 4 different muscles, including your supraspinatus, your infraspinatus, which is this big muscle here, and the teres minor right here. And you can see as these muscles become tendons that attach to bone, they form a cuff that goes around. What we don't see in the front is the 4th muscle, which is the subscap. But it's basically a cuff of tendinous tissue that goes around the tip of the shoulder right there. And what they do is they contract and they pull the ball down onto the socket, and they hold the ball of the ball and socket joint centered on the socket. And while your deltoid, this big muscle on the side, that contracts, and that when it does, if the rotator cuff sucks the ball onto the socket, the deltoid contracts and it creates a pivot point, so the arm raises up. And there's a whole coupling of motions where one muscle contracts, the other one releases, and in order to give you that excellent range of motion of the shoulder. Looking at the body from the front, this is your pec major here, big, large muscle of your chest. It's divided from your deltoid by the cephalic vein. Underneath the pec major, right underneath here, which we don't see in this picture, is your pec minor. And the pec minor is sort of, I think, a little bit underrepresented in these injuries. I think it's a big factor in potential injuries, and we'll get into a little bit why. Just keep that in mind, that the pec minor is there, it's underneath, and that can tighten up, and when it does, it attaches to your shoulder blade, the front of the shoulder blade, a little bony prominence called the coracoid, and it can start to pull that shoulder blade forward, which is a bad position for a thrower. It's a good position for a linebacker, not so great for a thrower. All right, this is the next picture. All of those muscles are now stripped away. Here's the coracoid I was talking about, that bone that sticks out in the front. This is this undersurface, the shoulder blade, the scapula. And you have this little finger-like bone that sticks out from the front there, and what attaches right to the tip of that bone is pec minor. What also attaches is the short head of the biceps right there. This would be the ball of the ball and socket joint right here, but it's covered. And it's covered, 1, you can see the tendons of the rotator cuff, which have been stripped away, but then 2, joint capsule. So there's like a balloon, a capsule that surrounds the ball and socket joint of the shoulder, and this is that capsule, okay? And the capsule is significant. We're going to talk about that. It plays a really large role in these injuries. So just remember, 1, you have your biceps tendon running right up the front of the shoulder, diving into the shoulder. That's the long head of the biceps right there. And then 2, just remember you have this joint capsule right here. All right. This next picture now, we've sliced the joint capsule open, okay? And we've opened up the joint like a book. All right, and over here you have the ball of the ball side of the ball and socket joint, and over here you have the socket side. Here's that biceps tendon that was running up the front of the shoulder, diving into the shoulder. This is really important in understanding these injuries, okay? Comes in and it attaches right to the top of the socket. Running around the entire socket is a rubber gasket. It's not really rubber, but it really looks a lot like rubber. And at the top of the gasket, the biceps tendon comes in anchors, and it attaches right here. All right, and then this would be the joint capsule on the inside, and then you see parts of the rotator cuff all around. These things are going to be a factor. If you can imagine when your arm is at your side like this biceps tendon comes up and into the joint and attaches right there. But once the arm is up and out and externally rotated more like that, this biceps tendon assumes more of a position where it rotates up and around and is pointing out that way. And it can actually begin to peel back on this labrum, superior labrum, top labrum, where it attaches. And that's part of this cascade of injuries that we're going to talk about. And I'm not going to get too detailed on it because I know it's boring, it's torture. But I do want you to have the basic understanding, so hopefully all of this makes more sense. Here's a live picture of what it looks like. I have a scope in the person's shoulder, and when I do these particular surgeries, I do them with the person on their side. So you have your socket, you have your ball, they're on their side, ball and socket on its side. Here's the ball, here's the socket very clearly. Here's that rubber gasket, the labrum that goes around the socket, and here's the biceps tendon coming into the joint and attaching to the top of that socket, just like that picture showed it. It's pretty amazing how well it's reproduced in real life. In this particular situation, this is where that labrum meets the socket, and it looks pretty well attached and well fixed. This guy has not yet had an injury, at least not in that spot. All right, so just another picture of that biceps tendon going up into the joint. You have a bursa over here, which sometimes can get irritated, rotator cuff attaching, and joint. You can see joint capsule, and the joint actually enclosed within the joint capsule. All right. One real quick mention of the elbow, hard to separate the two. This is looking at the elbow from the front. This is right here on this side. This is the medial side, or the inside of the elbow. What you have running over here is the ulnar collateral ligament. This would be the outside portion of the elbow. This picture here, we're actually looking at the elbow from the inside, kind of like this. I hope you guys can see me in this picture. All right. The ulnar collateral ligament is made of three main bands. Your anterior band, posterior band, transverse band. It's this one here in the front that really tends to get people into trouble. Now this next picture, similar picture looking at the elbow from the front, but it's been the joint capsule has been opened up. Ulnar collateral ligament still runs along this side over here. You can imagine every time you throw, there's a lot of stress pushing that, opening that inside portion up. As it opens that inside portion up, eventually this ligament here on the inside can get stretched out or even tear. As it gets stretched out, one is a nerve, your ulnar nerve runs along the inside, can start to become irritated. People will get some numbness and tingling into their fingers. Two, the muscles which help the flexor pronator muscle mass, which helps prevent that, can start to weaken. As it does, it starts to fatigue and get tired. This, the radial head on the outside of the elbow, starts to bang up against what we call the capitellum. You can start getting issues in this capitellum over here. And then if we look at the back of the elbow, here's your capitellum, here's the radial head, here's the capitellum. The ulnar collateral ligament is over on this side. As you can imagine, as this stresses and goes that way, the olecranon, the bone that's right here, the tip of your elbow, which sits in a little groove back there, starts to bang into the bone on the other side here, the end of the humerus, and you get what we call osteophytes or arthritis along the inside portion right over here, posterior medial olecranon. And that whole sequence of events is called valgus. That's that motion. Valgus would be to go this way, extension, overload. So if the mechanics are bad in the shoulder, then there's a lot of extra overload across the elbow, and you get valgus extension overload, which leads to elbow problems as well. All right. Now I want to go through the throwing motion a little bit. And I don't know, we may have, coaches on listening right now, and we may have little leaguers on listening right now. So please bear with me. This talk is it's targeted for all. So for some parts it may be boring for some, but it might be super interesting for others, and vice versa. All right. So the pitching motion, it's a kinetic chain, and it starts down in your feet and lower legs. There's an energy transfer from your lower legs where you stride and you wind up and you're corking basically a lot of kinetic energy or built up energy. And as you stride and torque and twist, it goes from your lower extremities to your torso, well, to your pelvis, and then to your trunk, and then up to your shoulder, and then it gets sent right up the kinetic chain, right up to the elbow, to the arm, to the wrist, and the whole time it's starting from larger muscles, working their way up to the smaller muscles, and it's all let out eventually as you release the ball. And so there's a lot of force that goes through the shoulder and the elbow, smaller joints, as it's pent up and worked up right on up through the body. And that's how these guys, these good pitchers, can throw a ball so hard, is because a lot of it's not all coming from their shoulder. It's this kinetic energy that works right up the system. The early model of the pitching cycle included just cocking, acceleration, and follow through. More of a modern version of this includes multiple phases, and I'm going to go through each one, but it essentially starts with wind up. Wind up includes knee up. And it ends with knee up, and then you go into your stride. And there's a little bit of overlap. This is a smooth, continuous motion, but if you're going to a stride, your stride basically ends with stride foot contact at the front. At this point in time, the arm is loading in the back, and this picture is not exactly perfect, but the arm is loading. We call that cocking, getting ready to really holding all of that kinetic energy as you're cocking and getting ready to release it. And at that point, an ultimate sort of level of kinetic energy built into it, the shoulders at maximum external rotation, and then it begins arm acceleration. And as your arm begins to accelerate dramatically with the twisting of your trunk, with throwing forward of your body, then you wind up releasing at the high point, which is the end of arm acceleration. Right after release, you begin arm deceleration. As the arm follows through your maximal internal rotation, then you follow through with your steps, and you want to leave yourself in good position to field the ball. All right, so wind up phase is, and I'm going to try to go through it relatively quickly, but hit some major points. From initiation of motion to the time when the ball is removed from the glove. It begins with the stride leg pushing off from behind the mound. And as we go through the mechanics, I have another portion of the mechanics where we're going through avoiding injury. I'm going to try to demonstrate a little more of it. The wind-up phase, both your arms basically flex forward. The pivot leg, which is the back leg, which for a righty pitcher will be your right leg, begins to rotate a little bit. As you enter your stride phase, where your hands come apart at the same time as your legs start, the stride leg, the left leg is beginning to go forward, and the knee begins to pivot over a flexed knee, lowering your center of gravity. The throwing arm or the throwing shoulder is being brought up into a good throwing position, and we're going to talk a little bit about that when we go through the definitive mechanics. And I'm going to do my best to stand up and hope that you guys can see me while I'm doing it. All right. Then the pivot leg, the back leg, vigorously extends during early arm cocking, which is really getting that arm into position. The hip and the knees begin to rotate. The trunk tends to stay closed. You don't want that shoulder to begin to open up too early. That's very important. So there's a lot of torque across the trunk, across the pelvis and trunk. The stride leg begins to plant. It plants towards home. The entire motion has to be going towards home. And you don't want it to be going to the side. You're wasting energy then. You want everything to be going in the direction towards the catcher. Eventually, the throwing shoulder begins to lag behind just a little bit as the arm reaches maximal external rotation. The trunk continues to rotate forward, chest going towards the catcher. The shoulder goes from late cocking to acceleration. You're beginning to accelerate the ball. Let's look at it from the top. Shoulder rotation is not purely glenohumeral. It includes some of the glenohumeral being the ball and socket joint of the shoulder, but it actually includes some of the shoulder blade scapulothoracic rotation. Trunk extension is part of that process. Through the acceleration phase, the arm goes from maximal external rotation through ball release. It is powerfully internally rotated in order to accomplish that. I wish I was more flexible and able to demonstrate it a little bit better. Within 1/20th of a second, the ball goes from 0 to 90 plus miles per hour, or if it's me, to 35 miles an hour. But in the guys that can really throw, severe or intense acceleration, and that places severe torque or intense pressures across the shoulder, across the humerus, across the elbow. Whoops, sorry about that. As the ball is released, then you go into a deceleration phase as the arm is swinging through. That puts a lot of stress on the posterior capsule of the shoulder. We're going to talk about that. And that puts a lot of stress on some of the rotator cuff muscles and the trapezius and the rhomboids of the shoulder, and slowing that arm down as you're coming through. And then the follows through, where your pivot leg then comes over the top, and you get yourself into your good, where the body catches up and you get yourself into a good fielding position. That's for pitching. The mechanics aren't quite exactly the same for just general throwing for the fielding position, but it all holds true. The mechanics are similar, slightly different, but similar. And you want to avoid injury as you're coming out of lockdown, as you're coming out of COVID. I wish I can tell you when it's all going to end and when you're going to be able to do a little more, but the truth is we just don't know quite yet. All right, adaptations of a thrower. And this is where it really starts to get more interesting. So normal physiologic adaptations happen. Throwers' arms and shoulders are different from those people who didn't throw growing up. The total arc of motion will frequently remain the same between the right and the left shoulder, but in a thrower, their dominant arm, that arc of motion is frequently shifted backwards. And so on the left side, let's say you're a right-handed thrower, you might be able to get all the way, you may be able to get to 90 degrees when your shoulder's up like this. So this being 0, 90 degrees of external and 75 degrees of internal. Versus on the right shoulder, someone who's a thrower can all of a sudden get to 110 or 120 of external, but they can only get to about 30 of internal. They've actually shifted that arc of motion backwards, and what it does, it allows them to get it allows their greater tuberosity part of the shoulder to clear the glenoid, which is the socket. But 2, it allows them to really get that far back, that maximum external rotation, so they can really generate a lot of force in that throw. Typically, there are bony changes. That increase in external rotation happens through something called increased retroversion of the humeral head. So our hips are anteverted. If this is your hip socket and this would be ball, our hips are anteverted. They're kind of pointing forward like such. And the opposite is true for your humeral head, which is in your shoulder, where it's actually retroverted, or pointing back the other way as such. The repetitive throwing can lead to a loosening of the anterior capsule, which is the joint capsule that we talked about, the front of the shoulder, and it can actually do the opposite to the capsule on the back of the shoulder. It can lead to what we call posterior capsular thickening or contracture. These things, and there's a different sequence and different philosophies on the sequence or the order of events on how they happen. It's probably different for different people, but these things are generally protective to a thrower until they're not protective, until they become the source of problem. And that's been termed the thrower's paradox. All right, so we're going to go through the pathology of injury right now a little bit. So I really try to kind of group a lot of it all into one slide, so we don't spend too much time on this, and we can get to avoiding injury and throwing mechanics, which will be the next topic. All right. So different theories on the pathologic cascade, and internal impingement is one thought, and why it happens was proposed by Burkhardt with posterior capsular contracture, and scapulothoracic dysfunction also contributes to it. All right, so what's going on here? The posterior capsule. Remember, I showed you that capsule in that anatomy picture a little earlier on. The posterior capsule. As people throw repetitive injury, as you're going through follow through, one of the thoughts is that you start to get some micro tears and small injuries into the posterior capsule. And the end result of that is that the posterior capsule responds to that by becoming a little thicker and a little tougher and a little more pliable, kind of almost like a little bit of scar tissue forming in there. And what that winds up doing is the center of the rotation, the ball on the socket, or the ball should rotate on the socket close to the center of that socket. But as that capsule in the back of the shoulder begins to tighten up, what it does is it actually shifts that center of rotation a little bit posterior, and pulls it a little bit up, superior. And in doing so, at first that's a good thing for a thrower in that it allows then the greater tuberosity, which is the edge of the shoulder where the rotator cuff attaches, to more easily clear the edge of the glenoid. All right, and then allowing it to easily clear the edge of the glenoid, the thrower can get their arm back to more further back into a position without impinging or squeezing anything back there. But eventually, as it continues to tighten up, then it can turn into a loss of internal rotation, so loss of that arc of motion, and you start to get something called a glenohumeral internal rotation deficit, termed GERD. The humeral head begins to sort of hyper-rotate too far backwards. In doing so, and because it's not centered very well, but it's actually off posterior and superior, you actually start getting some stretching out of the anterior capsule, the front of the shoulder. It's basically a cam effect because it's not seated set in the center portion of the socket. And then that can lead to something called rotator cuff internal impingement, which is different than the standard impingement, which if you've known anything about, is called subacromial impingement. You can wind up with what's called partial thickness rotator cuff tears from that internal impingement, because essentially what's happening is the rotator cuff is folding in and the posterior or the back of the labrum are getting squeezed between the glenoid socket and the humeral head, and you wind up with repetitive squeezing and bumping into it, and you wind up with injury to the posterior labrum as well as the rotator cuff. And then because of that position where the greater tuberosity clears the glenoid, the biceps tendon, I tried to show you that picture before, the biceps tendon kind of windshield wiper ring, it actually goes into a position where it's no longer pulling forward, and the biceps, which is built to resist tension, is no longer dealing with tension, but actually the biceps tendon comes up and over and begins to peel back on the labrum, and it also creates a little bit of a torsion, which the biceps tendon is not good at resisting, and that eventually leads to tearing the biceps anchor. So you get two things: you start getting some posterior labral tearing, you start getting detachment of the biceps anchor, and that together winds up being a slap tear. Typically a slap tear, which is a tear across the top of the socket. Typically a slap tear would be stands for superior labrum, top labrum, that goes from anterior front to posterior. Typically in a baseball player, you see these slap tears, and they go from biceps anchor and just back. They don't really go anterior. They don't go forward very much. So again, internal impingement, when the arm is up at what we call 90-90, 90 degrees of abduction, 90 degrees of external rotation, you start getting the greater tuberosity banging into the labrum at the posterior superior portion. So the superior labrum and the posterior labrum begins to tear in that posterior superior corner, and the rotator cuff also gets pinched in there and begins to tear. You want to have what's called a partial articular, close to the cartilage, surface rotator cuff tear, and a posterior superior labrum tear begins to happen. And it's exacerbated by hyperangulation in the arm. Hyperangulation in the arm is exacerbated by poor positioning of your shoulder blade. Here's a picture of that excessive glenohumeral rotation that I'm talking about. This is a right-handed picture, and I can't get my arm back there. Most individuals can't, but some pitchers can. 170 degrees of external rotation, very dramatic. Yet that's all it goes, 10 degrees of internal rotation. So from 0, 10 degrees, all right? The left arm went to 50 degrees. That's a 40-degree internal rotation deficit. By definition, that's glenohumeral, that's GERD. If you have a 40-degree mismatch, that's a problem. All right, and then the next comes your shoulder blade, scapulothoracic dysfunction. All right, so the position that because your socket is the glenoid socket, the socket of the ball and socket joint of the shoulder is attached to your shoulder blade, the position of your shoulder blade impacts this whole motion and articulation dramatically. So what can begin to happen is the scapula changes position over time, especially for guys that don't work on strengthening the periscapular muscles in your back, your trapezius, the rhomboid that we talked about, other muscles that are around the back. They go out, they bench press and do push-ups all the time, and they're built more like linebackers and less like throwers. You want shoulders back, tight strong back for this to maintain good positioning of your scapula. Once that scapula starts assuming what's called a bad position, that's been called scapular dyskinesis, so scapular bad motion. The abnormal motion of the scapula has been termed something called a sick scapula, which is just an acronym for scapula malposition and bad position. That includes inferior medial border prominence, so it starts to wing a little bit. That as it slides forward, that medial or inside border begins to rise up a little bit. People will get pain at the coracoid, that little bony finger that I showed you on the bony finger that I showed you on the front of the scapula. And a lot of that pain has to do with tight pec minor, which attaches there, which pulls it forward. Again, it's the underappreciated muscle of throwing injuries. And then that creates dyskinetic movement. So if the glenoid starts to do this, starts to rotate forward, right? When the arm comes back, because the socket is rotated forward, that angulation between rotated forward, that angulation between the ball and the socket is magnified, and that creates a problem. So those are the different things. So that's your sick scapula, and that also, as that rotates forward more, every time the arm comes back, the front stretches more, and the front stretching leads to loosening or stretching of the anterior capsule. You get internal impingement, you get stretching of the anterior capsule, you get tearing of the posterior labrum, articular-sided tearing of the rotator cuff. You can start getting subluxation of the shoulder and extra motion in the shoulder. It's a whole cascade and a whole process. And here's a picture of a thrower, and this is what you don't want to see. And you see this an awful lot. So parents, if you're listening, check your kids. And as they get into high school and then into college, you don't see it so much in little leaguers because it's just too soon. And really, to be honest with you, if your kid's under 10 years old, just let them go out and have fun. You want to work on some of the mechanics, you want to work on the basics, but this is too much. They're not going to get this stuff. Just go through it with them, revisit it over and over and over. But let them just go out and play and enjoy and have fun. And they're not getting injured from these types of injuries. But once you start getting to middle school, and once you start getting to high school, and once you start getting to college, this becomes a real big issue. In fact, some of those guys don't make the jump to college or don't make the next jump because of these particular issues, and they're not addressed along the way. So here is a picture of scapular dysfunction, and you can see on the left, this is a right-handed picture where the scapula lies, and you can see on the right the droop. You can see that the shoulder blade, you can see the difference. This is their spine right here, right? You can see the difference from the inferior medial border of the scapula to the spine on this side, all the way out to this side. This is protracted, lowered, and tilted out, it's a difficult motion to describe, but tilted posteriorly or superiorly. This is a bad positioning. This person is on their way to injury, and if that doesn't get corrected, they're destined for a shoulder problem. So this person goes from this, where the labrum still well attached, to this ball socket. You see the biceps coming in, and now you see this tearing along the labrum going across the back. That's your slap tear. This is what it looks like on an MRI. Here's your rotator cuff coming in and attaching. All right. Here's your slap tear this is the socket, this is the ball, and this is that undercutting, that tearing of the labrum. Here's the rotator cuff coming attaching, and you see how there's a little bit of a gap right there? Partial thickness tearing of the rotator cuff on its articular surface, not on the bursal surface, not out here, over here. Very typical pattern. You also will start to see sometimes cysts within the bone, usually before they get to the injury with some of the internal impingement, and that happens on the back of the humeral head, the posterior humeral head. We tend to classify, this is from a newer article, this 2018 article, where they group these some of the injuries into three different groups. The first are those people who just have internal impingement. And the internal impingement tends to happen at that late cocking phase when the arm is all the way back and up like this, and they tend to get more of that posterior pain at that point in the throwing motion. the cascade can progress, and then you can start to get some stretching out of the front of the shoulders. You can start to get irritation in the bicep tendon. They'll get then pain in the front of the shoulder during acceleration. And that's our job as docs, sports medicine docs, to know that part of the equation, not your job as a thrower. Your job as a thrower is to know that I've heard every time I get to here, that's not good, and unless I do something, this is going to become a more serious problem. All right, group 2 is internal impingement that has already acquired some of that secondary anterior instability, front instability, and they tend to get deep pain during that late cocking and beginning of the acceleration, because the ball is literally slipping, and sometimes slipping and subluxing and or dislocating at that point, so they get that deep pain inside the shoulder. And then finally, you have group 3, trying to keep an eye on time. The talk can easily run too long, and I just don't want that to happen for you guys. I think we're doing all right now. So group 3 is totally different from these ones, and those are the people who have what we call either primary anterior instability or even multidirectional instability, where the shoulder slides around a bit, and they get more of a non-specific pain, more of a dead arm complaint. And this tends to be that thrower that no matter what they do, they can't really warm up at the beginning of the game. We all know the guy where you know you're watching a game on TV, let's say, and the announcer say, yeah, if he can just get through the first 2 innings, he tends to do great. And you think to yourself, why doesn't that guy just go out and warm up earlier? He has this multi-directional instability, and that's his particular issue. And it takes the first inning or 2 for him to really get that under control. And then he pitches well for the next 3 innings, you know, and he gets to the 5th inning and whatnot. And then as his muscles begin to fatigue, he falls off a cliff. And so if he gets, every time you watch him pitch, you hope, is this guy going to get through this and not give up that run in the first 2 innings? And you think he's going to do it, and then, you know, there it goes. And he contains it and doesn't let too much damage happen. He gets through that first 2 innings, and then he's great for the next 2-3 innings. And then you say, oh, just get through the 6th inning, we can, you know, start going to our bullpen. And he winds up giving 4 runs in the 6th inning because he falls off that cliff. And so you guys don't need to know, but we need to know it, what kinds of pain and what kind of injury and how things present. That helps leads us to figure out what's going on in that in your shoulder or this particular shoulder. All right. And then real quick, as we talked about, you start having shoulder problems. This is the valgus extension overload. These are the elbow injuries. As the shoulder starts to hurt, the arm starts to drop a little bit more. As the arm starts to drop a little bit more, that leads to more stress across the elbow. The dynamic stabilizers or flexor pronator begins to weaken. You get more stress across the static stabilizers on the collateral ligament, the radial head, which I showed you, the olecranon sitting in the groove at the back of the elbow. You can start to get stretching out of the ulnar collateral ligament. You can start to get an osteochondral defect to the capitellum as the radial head bangs up against it. And then you can start to get those osteophytes and arthritis. And then you can see a lot of throwers, left arm straightens out all the way, right arm only gets to there. And slowly with time and over the career, it gets worse and worse. And so they need surgery to clean it out. All right, so how do we avoid all this? What are the best steps to take? Well, the whole world has experienced COVID-19. None of us saw it coming. We all went on lockdown. None of us saw it coming. Baseball season's affected. Every sports season, everything's affected. Theoretically, people aren't throwing right now. And so how do we get back to that? If there is going to be a baseball season, I don't know if there's going to be or not, but if there's going to be a baseball season, how do you get back on the field and how do you avoid injury? Truth be told, this shouldn't just be now. This should be every season, before every season. These are the same things that you guys should be doing to avoid injury. And you do it in your off season, the warm-ups you do it during preseason and in season, and your throwing programs. And we're going to go through some of that. All right. The most important thing, especially for a pitcher, the best way to ease stress, and you guys know this, pitch count, limited pitch count. Should not pitch more than 2 games in a week. Kids should not be throwing breaking balls until they reach puberty. Curveballs have been loosely associated with shoulder injuries. Sliders have been loosely associated with elbow injuries. Shouldn't do it. The idea is that once they reach puberty, a lot of the growth plates are beginning to close, and thus then they can tolerate a little more stress, the extra stress that's placed upon the arm and the shoulder when you're throwing breaking balls. you should have at least 3 months a year where there is no throwing. You're doing a different sport. You're doing something different. The shoulder and the elbow begin to recuperate, begin to rest. With sports being as emphasized as they are nowadays and sports becoming year-round, this becomes one of the bigger issues. I actually don't know if this is a true statistic, but my fellowship director, who was the head doc for the Pittsburgh Pirates, was adamant that the Northeast produced more professional pitchers than any other region in the country, and his take on it was because we have winters, and it's harder to throw during winters. And in Texas, where you have a lot of great ball players coming out, not as many make it through to the majors or to pitching because of injury, and you lose some of them along the way. And same thing in California and Florida and the warmer states. Again, I don't know if that's a true stat, but I will tell you that my fellowship director was adamant that that was true. Additionally, pitchers, throwers should develop in-season protocols on how they're going to treat and how they're going to bounce back daily after their throws. Their different routines that they should stick to. All right. This is out of a 2007 article from Job. I'm sure you've all heard of Carlin Job. He lifted it from an article actually from Andrews. Everyone's heard of Dr. Andrews. From 2004. So these numbers don't necessarily correlate from where we are right now, but these are recommended number of pitches, and also recommended rest after pitching based on number of pitches and the amount of rest necessary before you pitch again. And this is correlated with the age group. These are newer, and these can be found online. It's very easily. Maximum number of pitches, 110 pitches per game. This is New Jersey State Interscholastic Athletic Association for baseball, and these are the recommendations. And it's critical. It's critical for the health of our athletes that these are adhered to. And you guys know this already. At least you should know this already. And in the Little League, again, here are some of the recommended pitch counts. These are the recommended rest days after pitch counts. Again, this is easily found online. You just type it in, pitch count, Little League, and whatnot, and it comes right on up. Let's get into the mechanics. All right, so again, the most important thing you can do is adhere to the pitch counts. That's the most important way to relieve stress on the shoulder, relieve stress on the elbow. You also want to adjust your mechanics. You want the mechanics to be pretty good. I'm gonna mess around. I'm gonna see if I can still see myself as I'm going through it. I think we can do most of it. We're not going to get everything, but we can probably do most of it. So in the mechanics, one of the important, we're going to go through the mechanics. Again, I don't profess myself to be a throwing guru. I have a basic understanding of some of the mechanics and some of the things that can go wrong. But so if we're talking about a right-handed pitcher in general, you're going to have your pitcher looking in, right? You got your ball here, you're looking in, he gets his sign. When he gets it, after he gets his sign, generally he's going to, and what you don't see, I don't know if you can see, my feet are apart. They're not together, they're apart, a little wider than shoulder width apart. And as he gets his sign, he then steps up, brings his feet a little closer together, and brings his hands together. As I do, I tend to bring my stride foot, the left foot, a little bit, maybe 2 or 3 inches in front of my pivot foot, the right foot. My feet are apart, but the left foot is 2 or 3 inches out in front. My hands are together, a little bend in my knees, right? Now you're going to go into windup from here. And as you do, the left foot, the left knee, the left leg starts to come up at the same time that the hands do. More of an elbows down position, not all the way up like this, elbows down position. And as you do, you also see that the guy on the left here in our picture, he's leading more with his hips. He's not this straight up and down, but he's actually beginning already to lean in, and he's leading more with his hips. That's your position in what we would call early cocking. He's kind of sort of late wind up right there. Now, the next part becomes separation of your hands. At the same time that as you're going into your stride with the left foot, so with the left leg going into your stride, you're also beginning to separate the hands, and that's done down here. And that's really done with the internal rotation of your thumbs. So the ball and the glove, right? And as you come down, you're sort of internally rotating both sides right here. So the arm is down, both are down. As you're going into your stride, you're bringing your arms apart. As you do, your lead elbow, you're kind of leading with the elbow with your glove a little bit further behind, which is well demonstrated by our individual on the left. As you can see, the guy on the right, he's beginning to really open up with that front arm. It's not so much of a stride towards home plate for him. It's more this roundabout kick, which is going to put him into a bad position. Remember, you want this to be an efficient motion. So hands are coming apart. You're striding directly towards your catcher, towards home plate, bringing the arm up. That ball is kind of held back in a way, as you can see, back in a way as the arm is coming up. As you can see, the guy on the right is beginning to already turn it over. His elbow is down. The arm is beginning to come up a little bit, putting a little extra stress. And what all of this is doing is leading to opening up too early with the left shoulder. Now, as he kind of goes through his stride, you see the left on the left, our guy on the left, stride foot contacts going straight towards home plate. He most importantly, has his left shoulder, it's still closed. Elbow generally pointing, he's just getting ready to begin the torque where he pulls hard with the left elbow. And at the same time, right arm is back. Elbow is actually higher. He's showing the ball behind him. He's showing the ball back. And we can see our guy on the right doing the opposite. Arm is up. He's beginning to really open up. Look at that. Look at that left shoulder. The bad positioning of the left shoulder. He's beginning to really open up. It's caused his left shoulder has caused the left foot to plant too far open. It's not going straight towards home. He's kind of gotten this big wide circle like that and kind of pulled himself right out of it. He opened up too early. Here we are looking at them from home plate, that same exact position. You can see the shoulder of our gentleman on the left versus the shoulder of the gentleman on the right. You can see the foot positioning of our gentleman on the left, pointing straight towards home, versus our gentleman on the right, really opened up. You can see all that extra torque, and he's not going to generate nearly as much power, and he's going to wind up hurting his shoulder versus our more schooled and our more technical thrower. Still got that left arm closed. He's got a ton of torque in his trunk where it's all wound up. He's really getting to that late cocking portion where he has all that kinetic energy built up, and he's about to push off with that back leg, open up, so he points his chest right towards home plate, and that arm is at maximal external rotation, and then he begins his acceleration, his throw towards home. Again, you can see the foot. I don't have the final pictures there. I hate to say it, of him actually throwing his chest towards home plate and throwing towards home. And then when you finish, the pivot leg comes up and over, and you tend to, lots of times it'll come across your body, and you get yourself into a good fielding position. But even if it just comes up and then you're into a good fielding position, that's how you want it to go. So you see you can see how the kinetic chain is a big factor here. So my recommendation is begin now, right? Begin with strengthening now, and it's not just your arm, and it's not just your shoulder, it's the entire kinetic chain. All right, so conditioning begins with strengthening your legs. You want to check for weakness within your core. That's done with a simple way to check for this is dynamic Trendelenburg test. I'm going to show you that next. You want to work on trunk flexibility. Another good thing to do is work on stretching your pec minor. You can take a rolled towel and put it between your shoulder blades. You need a relatively hard surface. In a physical therapy office or in a training room, it's done on the examining table. But if you're doing it at home, maybe it's just done on the floor. A rolled towel, you put it right between your shoulder blades, and then someone pushes down on both of your shoulder blades to stretch your pec minor and to stretch that out in the front. You want to begin strengthening the rotator cuff, most specifically the posterior cuff, but really the whole rotator cuff. This would be a dynamic Trendelenburg test. It's done. You lift one leg up, and you do it for both sides, and you want to try to do a squat as you do your squat, what you don't want to see in your single leg squat is you don't want to see the knee collapsing inwards. At the same time that that happens, usually frequently the pelvis on the other side will begin to drop down. And then because of that, the person then will start to lean over the leg they're doing the squat, because otherwise as the pelvis drops, they can't maintain their balance and they'll fall over. And those are signs of a weak core. What you really want to be able to see is that person you can hold your knee going straight forward, try not to let it fall in, and then I'm getting old, it's a little harder to do. Up and down, straight forward, not letting it collapse in, not letting that pelvis droop. Those are your abductors of your pelvis, and if those are weak, the pelvis begins to droop. As the core gets weak, you try to generate strength by internally rotating, pushing off, and you shouldn't have to do that. That puts you at risk for an ACL injury, and that also indicates that you're not generating enough strength through your core, and you need to work on it. You need to work on that. All right, so how do we work on it? So truth be known, some of this is actually putting some of this together. I'm working on I've been working with one of my partners, and a good friend of mine, Brad Bernardini, and doing some exercises, trying to prevent running injuries as you're getting back into exercising, and those hold true here. So some of that includes reverse calf. Those are eccentric exercises that you want to do to try to prevent that injury. What eccentric means is working the muscle while it's lengthening. So what you're going to do, and it's going to be hard for me to show you, are basically reverse calf raises. So you go to the bottom step of your stairs, not the top, don't tumble down. Bottom step of your stairs, hang onto the railing, and you get on your toes. And then you lift up one leg while you're on your toes, with your heel hanging off the edge of the stair. You lift up one leg, and then slowly on the 10 count, you lower your body. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 2. So you go from this down to this. And then you use both feet, go back up, and you do the same thing. And you're doing it for both sides, and you're doing those every day. Nordic hamstring curls, and you would need help for this. It's a hard thing to do, where you're on your knees, and you're slowly, someone has to hold your ankles, or you need something to put your feet under so that you have leverage, and then you let your body slowly fall forward. Once you get to the bottom, you can push yourself back up, and then you do again, slowly lower your body. You want to do single leg squats, which are essentially that Trendelenburg test that we just worked on, and you need either a chair or a bench, and that you're being very careful about your knee going forward as you lower it. As soon as your butt touches, right back up. Same thing, butt touches, right back up. This one's too low for me, I'm struggling. You can do monster walks. That's how you're going to strengthen some of the abductors in your hip. So you do band, you have to get elastic bands. They're critical, they're great. Elastic bands, and you're walking, and you're doing your steps back and forth, all the way down, all the way back. And then finally, the last thing we added there was kind of a running man exercise. So I call it running man, I don't know what the real name is. So you got your leg up, kind of in this position where you're running, and you go from this straight out. So stretching out your glute all the way up and trying to maintain your balance. And in reality, you actually want to be able to do it going forward, going to the side, going to the side. So out to this direction, in this direction, and then going forward. And really, really getting that leg out there, really getting a full extension on it. Then you got to work on your core. The core is going to help out with every single sport. When I was working with the Pirates, planks and core work was the one thing that everybody complained about, because it's hard. It's really hard, but it's critical. And these guys, you know, they're great athletes, and even they are not in great shape when it comes to this. Either you do these exercises or you're weak, weaker than you should be. That's the bottom line. So you got to do these planks. Different planks, holding your body out straight. You can do low planks on your elbows, high planks on your hands. You can do Superman where you're lying on the ground and full extension, arms up and legs up off the ground. You can do alternating where you're in your plank, or you can even do it just hands and knees, and right arm, left leg go up, and vice versa. You're doing them on your side. This is the one that everybody hates, myself included. On your side, on your elbow, then your arm up, arm and leg up. And there's a whole series of exercises you can do, but that's how you build a lot of your core strength. And that's a critical portion to all of this. Another thing that you can do are prone walk out to deep squat. Lean forward, hands on the ground. So almost like a downward dog position, if anybody knows yoga. Walking out forward till you're in a high plank. You hold that position for about 5 seconds, and then slowly walk your toes, your feet up. So you're back into your downward dog position. Then you come down to a deep squat, and up you go. And then you give yourself a second or two to break. You can do it again, and you're walking across that way. You also want to order elastic bands if you don't have them, all right? So I have 2 similar workouts, elastic band workouts, that you want to now strengthen your shoulder, getting ready to throw. You want to do that now. This way, when we're able to throw, if it's in 3 weeks, it's in 3 weeks and whatnot, but you need to start that process now. You know, a very easy way to see this, and it's, so Kevin Wilk is a physical therapist that worked with Andrews. A very smart thing that Dr. Andrews did to add this gentleman to his team. And he's come up with something called the Throwers 10. He's also kind of dictated a lot of what the return to throw programs look like. But Kevin Wilk has something called Throwers 10. And if you Google Throwers 10 online on YouTube, you'll come up with a great series of exercises that you should be doing with those bands. But in general, what you want to do is hook the band up to basically a doorknob with your arm at your side, all right? I encourage you to use a rolled towel because it gives you about 30 degrees of abduction, which is probably a better position than completely at your side. But when you're doing this on a baseball field, once we get in season, you're not going to have that towel. But when you're at home, roll towel, and you're going to do 10 external rotations. And then you turn around. All right, so I'm going to say we have the band over there. You can do 10 internal rotations, again, at your side. And then you're going to have it hooked up there with your shoulder at 90 degrees. External rotations, 10. Then if it's hooked up behind me, internal rotations, doing your 10. All right. And then you're going to do reverse flies. So you have it hooked up to the doorknob, and you're going back with it, back. And then you're going to do it the opposite way. You're going to try to go from hanging onto and bring it up forward. Then in the preseason, you can go to touchdowns, which is it's hooked up behind you. And you have the bands, you're bringing them up. Touchdowns, and you can even do rotator cuff burnouts, where now the band's hooked up, it's in front of you, you've got your thumbs in. It's a little bit of a different, it's a similar motion, but it's done the opposite way, and your thumbs are in, facing you, and you're rotating them out and up and out. You're trying to build some strength in the rotator cuff. All right. Now we're getting closer to regular season. You've been doing your exercises in the off season, sort of building up preseason. Now it's time to get ready to throw. You don't just go out and throw. What do? Well, you got to warm your body up to be ready to throw. And remember, it's not just the shoulder, it's your body. So the first thing you do, and this is daily routine for your preseason routine and in season. This is what you should be doing before you start throwing the ball to avoid injury. First thing you do is a short jog, down and back to the fence, a couple times. Just start to begin to break a light sweat. Then you're going to do your high knee exercises. Then you're going to do your butt kicks. And you're going to do your trunk twists. And that's kind of just your full body, break a sweat, early warm up. Then you want to start to warm up your shoulders. And again, this is before you're throwing a ball. And you start with arm circles, small, getting bigger as you go. And then reverse, backwards. And then you're going to do your hugs, reps. Kind of alternating top and bottom, and then your swings, your alternating swings of your shoulders. That's more of your dynamic warm-up. Now it's somewhat okay then to go to more of a static stretching your arm across your body, stretching your arm overhead, and beginning your forearm stretches to stretch out your arm before you actually throw. All right, now you've done that. Different than the preseason, off-season workout, this is your daily routine warm-up. You should still be using those elastic bands, right? And so doing similar routine, arm, external rotation, internal rotation, external rotation, internal rotation, reverse fly, forward fly. But then instead of touchdowns and instead of the rotator cuff burnouts, do 10 reps of reverse throws, where the band is hooked up to the fence, because you're out on the field getting ready to play. The band is hooked up to the fence, and you're reverse throwing kind of up in the air. So from here, pulling it back that way, and then you do your 10 forward throws. All right. Then you start your throwing. And again, you don't just pick up a ball and start whizzing it. It's a slow buildup. You have to warm your body up. And it, you know, for the younger guys, it's going to be too much and they're just not going to do it. As you start to get older, you start to try to preserve your body. You start off with dart throws. You're on your knee. There's light throws back and forth with another guy. And then you start elbow throws from the knee. And then you do feet parallel. Nice, easy toss. Just simple. And then you go from that to a rocking throw. So it's a rock, 1, 2, and throw. And start and run and throw. And then into your stepping throw, where you step and throw. And these are all just very light tosses. And then once you get to that, and none of this is no throws on the line, no hard throwing. So now depending on where you are, if you're in your preseason, then you start doing, this was all the warm up to begin your return to throw exercises. If you're in season, now you guys start throwing. You start, 100 feet apart. You're throwing, again, soft throws, backing up, backing up, backing up, backing up, and not throwing it hard. And then as you start getting close to each other, then you can start really throwing a little bit harder and putting some zip on it as you're getting closer and closer and closer, and throwing with a little more velocity. But at that point, your shoulders should be nice and loose. If it's still preseason, right? The reason, I don't know who knows this or who doesn't know it, pitchers and catchers report to spring training 2 weeks before the players do, the position players. And why? Because it takes longer to stretch out your shoulder. So if you're in preseason, you need to start doing this. If there's a chance baseball's going to start in 4 weeks, I don't know. My gut is that there isn't. My gut is probably 6 weeks. This should be a 4 to 6 week program where you start doing some of this stuff if you can. Hopefully you have a backyard or somewhere you can start doing it and you can still be conscientious and socially distanced. And you do that whole warm up, and then you start this, a return to throw program. And it doesn't necessarily need to take all 6 weeks like these programs frequently do. You can start to skip steps, not so much at the beginning. You should really go slow at the beginning, and maybe as you're getting on in it, you can skip a few steps. If someone has gone out and they've run, 10 marathons, but they haven't run in a year, you can't just go out and say, I'm going to go out and run my next marathon. You have to start from scratch again. You got to slowly build up. Otherwise, you're going to get an injury along the way. And that holds true with throwing, where you need those 3 months of throwing off per year to maintain your shoulder. And when you get back into it, you can't just go throw again. You have to work back into it using one of these accelerated throw programs. One of these return to throwing programs. They're used after injury, and they should also be used as you're coming back to baseball. This one was from Wilk, the main guy, that the physical therapist that worked with James Andrews, and this is this from 2002. Reinhold was the lead author, so I put him, but it was Reinhold was in there, Wilk was in there, there's a few other guys that were in there. I think Andrews was in there. And this is the return to throw program that the vast majority of the other return to throw programs are sort of modeled after. They're all different variations of it, but this was the basis. And you can find any of them online and go whichever one you like the most. Things to worry about, and we're just about done here, and I appreciate your patience. Just coming in just over an hour. If the athlete begins to complain of a dead arm, problem. If they can't loosen up, problem. Soreness is expected. Soreness is not a problem. Pain is a problem. A loss in velocity is a problem. If they can't locate, particularly high, when they're trying to throw, especially once they start throwing off a mound, they keep missing high. That's a problem. If they fatigue quickly, they start developing popping, locking, or snapping in their shoulder. Especially, I will say this, benign clicks and cracks, I don't worry about. Painful ones are a different story. And those can all be signs if someone's heading down this road towards one of these injuries, partial thickness rotator cuff tear, slap tear, what have you. And frequently those can be prevented if you shut things down early, start doing some of the exercises, and then slowly work back towards it. So if these things are developing, that's what you got to do. As much as you hate it, back off temporarily. If come in, talk to your athletic trainer, talk to a physical therapist, or talk to one of us, talk to us docs, and we'll try to guide you and get you in the right direction and try to help you avoid that slap moment when the tear happens. We try to catch it before it's too late. All right. Any questions? I don't even know how to check if I had questions, but I'm trying.
I'm here, Dr. Frey. I haven't seen any questions come through yet. If you have any questions, the top right-hand corner, you'll see a little bubble box. Just click on that. That's our chat box, and feel free to type in your question there, and Dr. Frey will go ahead and answer that for you.
It was a lot of stuff. I hope it was absorbed. I hope it was helpful. I hope it kind of got things right in terms of. Oh wait, do we got one?
It looks like it was Eddie who was trying to talk, but I had remuted the mic. Are you okay with somebody asking the question as opposed to typing it?
Yeah, sure.
We'll talk about this a little bit later as well, but
Maybe that was a coach who was on here. I don't know.
Oh no.
Does anybody have any questions? You can go ahead and unmute your mic. There's only two people left, Eddie and Steven. Well, if there's no questions, Dr. Frey, thank you again for your time this evening.
Sure.
If anybody has any follow-up questions, you can feel free to give us a call at the office, and we can go ahead and direct those questions to Dr. Frey for you. Other than that, I guess have a good night, everybody.
Hope it was helpful. Take care.
Thanks, Dr. Frey.
Thanks.